Hello everybody. This presentation is going to deal with surgical considerations for flap or flapless surgery. So when we're talking about the indication or looking at can we do flapless or do we have to do a flap, the consideration is we look at the width of the bone. And a wider bone generally has more good, soft, stable, keratinized tissue. And that's the second thing we look at. Undercuts. Where do we have to position the implant? How severe are the undercuts? And do we need to find important vital structures, such as the neurovascular bundle, the metal foramen? Or do we have to do manipulation as any sinus or grafting procedures? So what are the advantages of flapless? Well, we keep the periosteum on the bone. So where bone gets its blood supply from two sources. One is periosteum and one is the nutrient canals in medullary bone. So the advantages of flapless surgery, it preserves the blood supply. Also, there's less patient discomfort because it's minimally invasive. There's no sutures, there's no incisions. So it's a good marketing aspect to the patient because they have no pain and they tell their friends they have no pain. It was easy. So here's some illustration of a case, flapless in a maxillary premolar site. And the site was grafted 6 months ago. The tooth was extracted and socket grafting was performed, and which we discuss in our actual 1 and 2 day hands-on courses. So we had good bone fill, we had good amount of keratinized soft tissue, and no further grafting was required. And that's one of the qualifications, again, for flapless, that there's no grafting needed. So here we see entering in, right in through the tissue into the bone with a twist drill, 2 millimeter drill, and you can see we're going anterior to the mesial wall of the sinus. And you can see we did this a number of years ago. And probably, I would guess, about 14 to 16 years ago. And again, we had a nice wide ridge, good keratinized tissue afterwards, after we had regrafted it. And you can see my idea is I like to keep the implant in line with the adjacent teeth, with the central fossa of, in this case, the premolar and molar. So we can see the advantages of a tapered implant, like inclusive. And we see that the implant, we can use a longer implant in a constricted anatomy and with a wider prosthetic table. You can see this is tapered, we're away, but we can keep the implant in a better position for the prosthesis. So here you can see 12 years in function, a radiograph. We can then colorize it with the program that's in the digital computer. And we can see that we have air, and we have tissue, and then we have bone. And we can see how well defined this is after being in function even at 12 years. So here we see an implant that was placed flapless at 4 months, and we see good healing, and it was a 1-stage with a healing abutment. So we remove the healing abutment, and we see close up some little patches of red, and that's not inflammation. That's where the surface epithelium stuck to the healing abutment, and we unscrew it, we take away a little of that surface. And then the prosthesis, or the prosthetic part of it, is just taking an impression with an impression coping and sending it to the laboratory, and the laboratory gives you back the abutment and the crown. So here the abutment was sandblasted because it was short. The other option here is we could have done a screw retained, and in those days it wasn't as fashionable as a fixed abutment and cement retained. So here we just made a ceramic metal restoration. So single implants posterior. Predictability of single implants, success rate is an average of 20 25 years. 3-unit bridges, according to the American Dental Association, is 5 to 9 years. And the most common cause of failure of 3-unit bridges is recurrent caries. So implants preserve the bone. In the bridge ponic area, the bone is going to continue to resorb. That's why when you see a patient that's had a bridge for a long time, say the bridge comes out, if you notice the ridge is very thin where the ponic area is. So we look at the anatomy of the posterior mandible and the posterior maxilla. We're going to be dealing with the sinus, the maxillary sinus. And here in the mandible, we're dealing with, first of all, the submandibular fossa, which indicates angulation, trajectory, and the neurovascular bundle, which is the inferior alveolar foramen, and the inferior alveolar canal. And again, you can see the use indication or the advantage of a tapered implant is that, again, in an anatomically constricted area, we might be able to use a longer implant with a wider prosthetic table. So here's some examples of some cases that I did years ago when we were doing flapless. The implant designs may change, and but again, some techniques that we've used, proven through the years, we've kept with. Here you can see on the left, 25 years, another one at 15 years. Again, much more predictable than a 3-unit bridge, especially if you take this root canal tooth and you put a bridge on it, you probably wouldn't get 3 to 5 years. And then we see this a lot in my practice because my practice is strictly implant and implant prosthetics. So we see a lot of fractured endodontic teeth, pre-implant therapy. So we look at the clinical examination when we're considering doing a single tooth posterior. We look at the height and width of the bone. Again, I'm thinking, can I do this flapless? Undercuts, the amount of keratinized tissue, which is stable tissue. The opposing dentition. Did the opposite tooth move? Is there space there that we can place an abutment or we can place a restoration? Does something have to be done in the opposite arch? So radiographic examination, simple periapicals, panorex, lateral view, and a CT cone beam. And most of these, we just do this with a panorex and periapical. But again, you can see implant positioning. So again, using a tapered implant, we can have it in a more favorable trajectory to the opposing dentition and a wider prosthetic table. So here's an ideal case for flapless. Good keratinized tissue, a wide ridge, and again, we can keep it pretty much in line with the frontal fossa of those adjacent teeth. So we have a bone caliper. Again, we can measure from the buccal to the lingual. These have a needle on it, and we can go back and see where you can see where the needle has made a mark. So we anesthetize the patient, take the bone caliper. Here we had almost 12 millimeters of bone, so we can put in at least a 5-6 millimeter diameter implant. So we have a 2 millimeter twist drill and a tissue punch. So you can see we can take a drill guide. There's many of them available from different sources. On a 2 millimeter twist drill, and enter into maybe 5 to 8 millimeters, and then check it. You can see the end result before we finish. So it gives you the lineup. You can see we want to be, again, a little closer to the lingual bone. It's denser. And bone resorbs from buccal to lingual. So now we're using a tissue punch. And you can see there's more keratinized tissue, and we're not taking it away. There you can see exactly what you're doing. And then the sizing drill, and then we can place our implant. Now, generally, wide ridges are softer bone. So we look at this as about type 3 bone. So there's no need for a thread former and or a screw tap. So we go directly to the implant and self-tap it, achieve our 45 Newton stability, You can place a temporary abutment. You can place a healing abutment. And since it's in a non-aesthetic area, really, we can place, I prefer to put a healing abutment. After 3 months, we take an impression, and then the laboratory makes a custom abutment. In this case, we can use a custom abutment and a Bruxer crown. And here we're doing an illustration of implant-protected occlusion. And what that means is, in patient is closing and tapping and light-centric, we just have marks on the adjacent teeth. And when the patient hyperfunctions, we tell them to squeeze, bite hard, then we pick up on the crown. Because teeth will compress and the implant will not. So if we just have all even markings, when the patient would hyperfunction, most of the function would be on the crown, on the implant crown. Also, we want to eliminate lateral contacts. Teeth don't like it, and implants don't like it as well. So again, you can see this is over 5 years old, and you can see that the height of the bone and no evidence of any bone loss. So again, the advantage of a tapered implant here we can show, just like the first case, mesial to the anterior wall of the sinus. Now, here's an example. A patient comes in, and I know all of you have seen these patients in your office. A root canal tooth that's no longer functioning. It's all fractured, and it comes out in fragments. You remove it in pieces. And in this case, I recommend grafting the site, doing socket preservation, and using whatever bone that you're used to or prefer. And so now you can see where we've augmented the ridge, and we can go in 4 or 5 months, and you have a nice wide ridge. So here's the model, and we can take our bone caliper on the cast. And here on the cast, now this is stone, it's not soft tissue, it's 14 millimeters. We measured 50 patients. We know that this soft tissue is not telling the truth. So if we take 14 and subtract 5, which is the average of the 50 patients, that there was actually 5 millimeters less from when we measured on the stone caliper. So here we can actually put in a 5 or 6 implant easily, and doing it flapless because we have very good keratinized tissue. So here's the stages: the extraction, the socket grafting, and then the implant placement. Going back in 4 or 5 months later, because this was a grafted site, so I prefer to go back in 5 months. We could do healing abutment at the time we placed it. It's protected, and we did achieve primary stability. And then the laboratory provided back a custom abutment and a Bruxer crown, and we have something that reproduces nature very nicely. And the patient's happy. So are we going to do a screw retained or cement retained? So interocclusal space on an abutment retained, we need 8 millimeters of interocclusal space. This is average. On screw retained, we can have less interocclusal space because we're going directly to the implant, so an average of 6 millimeters. So here you see some examples of screw retained. I don't like this, and I'm going to criticize here myself. I would have preferred if they had the implant in a little better position to have this screw in here. This would have been better with a custom abutment and Bruxer crown. These are Bruxers. This is Bruxer screw retained. Here's another example. Now, this is better because the screw is more to the center. So we avoid off-axis loading, keeping it vertical. So this is some other examples. So again, these are Bruxers. So what about custom fixed abutments? And we have, what are the advantages? Precision margin placement according to the contour of the soft tissue, especially important in the aesthetic zone. In the aesthetic zone, I only do custom abutments. shaped to provide optimum retention. So we want to have the crown, even if we use provisional cement, we want the crown to stay on until we want it to come off. It allows for acceptable aesthetics in the anterior, and I would say more than acceptable, and more importantly, acceptable to the patient. So cement retain, recommend the use of provisional cement. Care must be taken to remove any excess cement. Residual cement can contribute to implant failure. Many articles have been written. It's happened to me. Anybody that says it never happened to them, maybe it didn't happen on the one they did. But it happens, and we take more care so it doesn't happen. So here's an example of custom abutments that this laboratory made for me. They've been doing all my lab work for the last 3 years. And we see the custom abutments and Bruxer crowns. We see the advantage, shaping nicely the margins to the soft tissue. And here we have implant positioners. These, I call them like implant jigs, abutment jigs. If we're dealing with, say, a conical abutment that has 6 possible positions, here ensures that you have the implant in a proper position and you're not having to play checkers where you're moving it around to make sure it's in a good position. So again, you see this nice contour. And then when we make the crown, even though it's not in the aesthetic zone, it looks nice, especially next to this gold crown. So here we see 2. And in the posterior, and my belief is that we splint in the posterior when we have 2 implants adjacent in the posterior because there's 4 times vertical load. So this is a single one in the anterior. Again, this is the implant positioner. This is the Bruxer crown, and we can see a good fit. And here's where we splint to 2 because there's 4 times vertical load in the posterior compared to the anterior. These are just some more examples. Again, you can see the advantage. If you take a store-bought abutment, it's very difficult for the technician to prepare it exactly to the gum line, and compared to being able to do it with the scanning and CAD/CAM techniques that this laboratory can do. So we say that the sun never sets on the possibilities that afford us in implant dentistry and the new innovations that are down the road. And I say the sun is implant dentistry. The future is so bright that we have to wear sunglasses. So thank you for watching. Have a safe journey in implant dentistry. And here's my contact information if any has any questions that I can help you with.